That's it. That's it, surely.
Oh, here we go. So, let's see whether Mikhail has answered the question.
So the first question was, can we use a risk score analysis for timing purpose?
So I think it's quite complex. There are many. It's multifactorial, and I think, of course, like the Euroscore, it's very good to use a risk score. But it would be, for me, it would not be decisive, but it would be a help. So that you don't forget any risk factors, etc. So I think it's very useful to develop something like that.
And then the next question, obviously you showed us the case of a very sick patient who's done well with a total artificial heart. I just wonder whether people would feel that it is appropriate and good use of resource. I know that your patient was very young, 38 years old. That was probably one of the very few options left for him.
Yeah.
What sort of percentage of that kind of patients do you think would survive a total artificial heart implant?
So I can only estimate, but I think 10%. 10%. I would say about 10%. So I'm not sure if you should do that or not. Yeah. So it depends, and I think it's the best to take much more healthier patients. And I think our destination therapy candidates very often these patients they come to us and they say life doesn't make any sense anymore. I cannot go up the stairs, I can walk 10 meters and then I'm out of breath, It doesn't matter when I die, but maybe you can help me. I think that's the best. They are in a more or less good condition, their organs are okay, they don't have infection, and then you can electively implant an LVAD, and they are very thankful.
Yeah. So do you think there are absolute contraindications to using ventricular assist device or mechanical support?
So I think, what for us is when the patient doesn't have any backup, when he's completely alone. So that's sometimes we do when it's a young patient and you can organize it, but that's maybe a difficult situation. It's not absolute, Then, of course, patients with alcohol abuses or, these patients are, of course, very difficult to assist. So that's these both categories, I think these are sometimes, I never would say never, but you have to take care before you assist them. Yeah. And of course the patients I described who are infected in a very, very bad situation, you have to evaluate every patient extra, more or less.
Okay. Then the final question is, with the small devices like Circulite, do you think we are at a stage that we can consider implanting those kind of devices into patients much more early, to ambulatory patients?
Yeah, it's a difficult question, because sometimes we have trouble with our LVADs. They have an LVAD and then the inflow cannula is not positioned very well, so they have a flow of not 5 liters as expected, but they have a flow only of 3 liters. These patients are always in a bad condition, But of course, we always implant New York Heart Association Class 4 patients, so they need full support. So, and at the other hand, when you have a patient New York Heart Association Class 3, they can, they have some quality of life. They can walk around, they can go up the stairs, of course they are impaired, but so when you put in a Circulite, they have their bag, they have their batteries, they have their controller, So for me, it's a difficult decision, what is better, to walk around with a bag, with a controller, with batteries, so you can walk a bit more, or, you just stay as you are, and wait when you are worse to get a real LVAD.
Yeah, I agree. It's a difficult answer. I find it a real pain to charge a mobile phone, let alone having to charge a VAD 3 times a day. Yeah.
Yeah.
Okay. Thank you very much indeed.
Thank you very much.
So we'll move on to the next speaker, and that's